asymmetry. And as I told you, you will see this slide through this illustration throughout my lectures, the 3 main modalities of breast imaging. Okay, yes, we have already passed this Pink October month, the awareness month for breast cancer. However, we agreed all together join the fight for breast cancer, supporting awareness, not only in October, but also throughout the year, and make it pink. As you know, breast cancer is influenced by hereditary, but it can develop even without having a family history or carrying genes for the disease. And if the family history is present, genetic testing might be requested. Please do your annual mammogram and be aware that if you notice any change in shape, appearance, size of your breast, please you should inform your doctor. Okay. Breast asymmetry, it can occur regarding the size between the two breasts or the nipples, okay, the shape or position of the breast, which is very common. However, our session today is not concerning about this type of asymmetry, which can be corrected surgically. Our concern is regarding what have been seen on mammogram as asymmetric appearance or findings. And the radiologist will examine a mammogram to look at the difference in position, volume, and form of the breast. And in most cases, yes, breasts are generally symmetric in their density and architecture and composition, but sometimes report reveal asymmetric density, which is common findings. Asymmetry in this pattern most commonly represent normal variations, but may also be sole presenting features or signs of cancer. Differentiating between normal variations and suspicious findings is the most challenging aspect of mammographic interpretations. And in the past, the asymmetry was typically regarded as sign of malignancy, whereas now it is nearly always regarded as benign. And that is why, because improvement in mammographic techniques have enabled radiologists to better distinguish benign from malignant breast tissue, and the ability to make further fine distinction on mammogram has also allowed the development of more specific criteria for ordering additional view. Even though soft tissue asymmetry is considered benign, increasing density or other change over the time might be of more concern, and malignant asymmetry is often subtle and can appear identical to normal fibroglandular tissue. Getting called back after screening mammogram is fairly common due to asymmetry. In fact, fewer than 1 in 10 women called back detected breast cancer. Mammographic abnormality, BI-RAD breast lexicons is strongly recommended, as we described before, including masses, asymmetry, calcification, architectural distortion, and rare important intramammary lymph node and skin lesions, and rarely present solitary dilated duct associated feature, and describing the lesion locations. Okay. The learning objective of these sessions is understanding mammographic definition of asymmetry as described in BI-RADS, know how to differentiate asymmetry from mass, understand and describe the BI-RADS definition of the different type of asymmetries, discuss a practical workup of asymmetric mammographic findings, identify associated benign and malignant causes, understand the positive predictive value for malignancy of different types of mammographic asymmetries, understand mammographic, understand management of different types of mammographic asymmetries, recognize the advantage of supplementary mammographic views and other modalities for asymmetric mammographic findings. Huh? What is Barat? Quickly.
Barat 5.
5. Why? Quickly, tell me, this is
speculated mass.
Speculated mass representing Barat 5 or coded as Barat 5. And this one?
Fat containing different density mass or
Mixed
mixed density mass, Hamilton.
Yes, Barat?
2.
Barat 2. Okay. And this?
Another fat containing mass, Pyra 2, Hamilton again.
Mixed density. It's okay. So we said the definition of a mass.
It's a three-dimensional space-occupying lesion that should be seen in at least 2 orthogonal mammographic views. And it is described by its shape, size, and position, and it has an outward convex border.
Yes. Why it is important? Why I brought again the definition of the mass? Because it is important to differentiate it from asymmetry, to make sure what is the difference. One of the objectives, learning objective of this session is to differentiate between mass and asymmetry, which is really important. Okay, so we said the mass is a space occupying lesion, a three-dimensional space occupying lesion seen in 2 different orthogonal mammographic views characterized by shape and contour, which is convex outwards borders, partially or complete, okay, having a consistent shape on 2 different projections and appear denser at the center, radiodense. And if it is seen in only one projection, we consider it as asymmetry until proven or confirmed to be a fulfilled criteria of a mass. Okay? And we said we describe the mass mainly by the morphology as well as density. And regarding the location, size, like other lesions, we have to describe and the associated features. But the main related descriptors are morphology, which include the shape, either regular, over rounded, or irregular shape, and the morphology regarding the probably benign lesion is circumscribed and obscured, and the suspicious margins, including ill-defined, microlobulated, and more suspicious, speculated. And we said there are 2 examples here: oval opacity, radio-opaque mass. One is circumscribed, probably benign in a case of a fibroadenoma, while the other one indistinct margin due to complicated inflammatory cyst. And we describe the density of a radio-opaque mass in terms of low density, high density, equal density, and we describe the positive predictive value is for malignancy is more with a high density representing 70% and 22% for equal density, and much low and rare with low density, but still here this is a case of invasive carcinoma presenting as a low density mass. And we said any fat containing mass representing Pyra 2, typically benign mass. Okay. Also describes the associated features, as in this case with skin thickening and trabecular thickening in a malignancy, as well as malignant type of calcification in indistinct mass representing Barat 5, compared with this typically benign, partially obscured mass with the popcorn calcification in case of involuted fibroadenomas. Okay. Huh? Any volunteer? This is the new case. what could you see here? Everything in front of you, even the ultrasound. 2 rows. The first row represents CC and MLO, and the second row represent the CC and MLO.
Yes. Added density, but does not meet the definition of a mass.
Okay. Okay.
It is in the upper one is upper lateral. The second one also is upper lateral.
Could it see in the MLO?
The first one, no. No, the first one I
Yes.
Cannot see. Yes.
Yeah. The first row you can see small focal asymmetry in the outer CC, not
yes.
appreciated in MLO. So it represents
asymmetry.
It represents an asymmetry. So it's probably benign. So okay. Or consider just an asymmetry, and the second round screening mammogram or a follow-up mammogram demonstrate.
The second row, the lower low, it is appreciated in both.
So
so it is focal asymmetry.
It is focal asymmetry. Okay, now you will call it as a focal asymmetry, or you have another name for that? Yes, it is a focal asymmetry, but what is the exact name for this asymmetry? Do you know it?
Developing.
Excellent. Developing. Why you said developing asymmetry?
Because in the first mammogram, it was not appreciated in the MLO. Now it is well appreciated, and the size as well. I see it is increasing.
Yeah, more conspicuous, more presenting, more obvious, and even the size, it looks like a larger than the previous. So is a progressing focal asymmetry, and this is a developing asymmetry, and in the spot magnification is still present, not fading away. That means it is real. And on ultrasound here demonstrating small mass, and it was a cancer, you see. So this is early detected breast cancer. Okay, what about this? Medina, Abir, Suhair, Heidi, Hana, Sarah, any volunteer quickly would like to go quickly to complete the on time? And you have arrow. Did you hear me? Okay, any volunteer?
Again, an area of asymmetry in the left breast, in the upper outer breast, seen in both CC and the MLO.
Could you see it in the in the CC?
In the CC, yes, I can see. In the outer part.
Excellent. You suspect it, yes. But the person who reported that case, he did not see it, or he could not appreciate it, you see, and he put the arrow here. And in this case, we can say what?
If it is seen in one view only, we call it asymmetry.
We could see it, you could see it here in these two views, but it could not be reported either due to misdetections or the asymmetry is obscured. Either he misdetected, okay, or obscured. Let us see the second round. This is after 1 year, the follow-up ultrasound. So as you mentioned, same, you describe it here, you suspect it, it is there, yes. Now we consider it, but less well appreciated. Yes, it is seen here, but not as the same as the previous. What do you think the cause for that? Why? So the asymmetry or the focal asymmetry is there, it persistent. But why you could appreciate it in one view, and the second mammography follow-up, you could appreciate in the other view and less appreciate in this view? What is the cause for this?
Maybe inadequate compression.
Different what? Yes, you are right. Because you are right.
Yeah,
because
different techniques of positioning.
Yes, yeah. It is related. It is related to mammographic positioning and compressions. You see, from time to time, the rolling and the breast is pendulous, is moving. So the directions of compression and the amount of compressions, as well as positioning, might be different from one to another. You see, and even if you look here, the pectoralis high up in this mammogram and here a little bit lower. So there is definitely different in positioning. That is why, you see, and the amount, even if you look here in this CC view and here retromammary fat is better visualized, better depicted. So the difference in positioning and the exposure of the breast, okay, and the involvement inclusion of the breast tissue different from one technique to another. That is why result in some change in positioning of this, but it was there, it is present since it is seen in at least one view. So we have to go further, and this is the ultrasound demonstrate a suspicious match proven to be malignancy. So given the likelihood that positioning will vary from one examination to the next, it should be expected that the region of asymmetry will be seen at least in one view. This is a lesson from this example. You see, if you have seen it and you did not see it again, don't say it is not there since I could not see it. Look at the other view and look for this view and go for ultrasound. Otherwise, you are going to miss cancer. We are always aiming to pick cancer as early as possible when it is curable, to improve prognosis. Okay, this is my patients. Any volunteer? Long time before this case. Can you see any, could you appreciate any abnormality? Quickly.
I think asymmetry in the nipple.
Who's talking?
Heidi.
أيوة Heidi.
Asymmetry in the nipple.
Which nipple? So the nipple, what about the nipple?
Not symmetry in the right.
Do you think there is pathology or no? On which side? You're right. Go ahead. Would you appreciate any asymmetry? It's okay. In other way, would you appreciate any asymmetry? Because our concern today, you see, our lesson is regarding breast asymmetry and differentiating from mass. Could you see a mass or could you see any asymmetry?
Yes, there is hyperdense area in the in the right breast.
Excellent. Where in the right breast? This is MLO or CC view.
What?
The view, the projections is
CC.
lateral oblique or craniocaudal.
CC view.
Is a CC view. So in CC view, you will see upper or lower or outer or inner. Regarding this part of the breast is this half. And this half. The asymmetry here or here?
Up.
Here. In the CC view, the upper part is representing, the upper half is lateral. This is lateral. And the lower half is medial. And at the level of the nipple, central. So, and here, this is anterior, medial, and posterior. So, the asymmetry where? Anterior, middle, or posterior? You are talking about this or different place?
Yes, about this, yes.
About this. So, this is the anterior, this is the medial, and this is the posterior.
In
you
the
are
middle.
dealing with in the middle.
The middle.
Okay, this is outer, and this is inner, and this is central. So,
central.
Mid-central. Plus mid-central. It is a mid-central toward posterior. Yani from middle to posterior depth of the breast. It's okay. This is the asymmetry. And good you pick, there is subtle changes regarding the nipple. Okay. This is the MLO. When you see an abnormality in one view, you have to look for the second standard view. Yes?
Yes.
I brought for you the second standard view. Could you see it? Could you see an abnormality? This is a CC view. That is the area you have seen on the CC view.
Yes.
Could you appreciate it in MLO?
Yes, still in the MLO.
Where in the MLO? Now in MLO, we have superior and we have inferior and we have central. So?
Now inferior.
Yes, it is central to inferior part. From the center, inferior. Yes. Yes. So we are dealing with more real, and something real seen in two projections. Is it a mass or asymmetry? The next question. Can I call it a mass?
Yes.
Why? Huh? Do you know? Okay. Any volunteer? Any other volunteer?
It lacks the conspicuity of a mass.
Yes. Yes, it's not a typical, it's not fulfilled the criteria of a mass. So we call it as a asymmetry. So this is an asymmetry, but since you describe good, Heidi, you pick subtle findings. Yes, there is asymmetry, there is thickening in the right nipple. Even in MLO here, there is some thickening Even there is some thickening around the nipple area, areolar regions. You see, there is subtle edema, and there is density here, part of density. So this case it was invasive cancer of the right breast. Okay, it was right breast cancer presenting as asymmetry. Okay, so what is asymmetry? What is asymmetry? We describe the mass. Now let us see what is asymmetry.
It's an added density that is seen in one of the breasts. It's either seen in one or more projections. And it lacks the characteristics of a mass.
Okay. Yes, again. So it is
an added density in one of the breasts, and it is seen either in one projection or more, and it does not fulfill the criteria of a mass.
Okay, so it is a spectrum of mammographic finding represent unilateral deposit of fibroglandular tissue, not conforming to the definition of radiodense mass. Okay, seen as discrete area of increased tissue density with no mirror image correlating in the opposite breast. So I'll see it in, as we have seen in the previous example, we could see added density, more density, one more brighter area having no mirror image in the contralateral. When we compare it with the opposite breast, it is not seen there, okay? And not fulfill the criteria or the definition of radio dense mass, and it's completely lacking borders and conspicuity of a true mass, as either seen in one projections, mammographic projections, as one type of asymmetry, or the other types, those seen in more than one projections, cannot be accurately described using the shapes and are planar, having concave rather than convex border of a mass, lacking the convex border of the mass, and are usually seen with interspersed fat within the density. In contrast to radiodense, we said the mass at the center is radiodense, okay? While the asymmetry demonstrates some fat in between the density, okay? And this is an example to differentiate or to show both mass or asymmetry and a mass. What do you think?
On the left side,
both are masses.
Okay, huh? Who's talking, Suhair or Abir or whom?
both of us are talking simultaneously, doctor.
Okay, that's okay. One of you, huh? Abir, huh? Next.
I think both of them are masses.
Both of which are masses. Why?
The first image on the left of the screen, the left side of the screen, is showing rounded mass in the posterior, sorry, in the inferior and medial part
the
of
location.
the breast.
Ignore the location. Just tell me, is it a mass or and why this mass and why this mass?
It is rounded, has concave, sorry, convex border.
Okay. Yes. And
it's seen in both
seen in both
views, PC and mediolateral
with
oblique.
persistent shape with persisting shape and complete convex borders, and it is opaque. Throughout, it is opaque. Okay. So
the other one on the right side of the screen, it's also mass because it has circumscribed margins seen on both views, mediolateral, oblique, and CC view, persistently.
Are you sure?
Equal density mass.
Okay. So here, do you agree with her?
Assalamu alaikum.
Walaikum assalam.
The first two images on the left side are the mass, and
Okay.
the two on the left, the two on the right side representing asymmetry.
Why it is an asymmetry?
Because it not maintain its shape on craniocaudal. The shape on the mediolateral oblique does not maintain its shape on the craniocaudal view.
What else?
It is not seen as a rounded mass on craniocaudal view.
Not necessarily rounded. It can be irregular, but it has no persisting shape. Okay, and there are what else? Even there are lucency within. There is some fat. If you look for the parenchyma here, this is heterogeneously parenchyma. If you look for this, it looks like more or less another focal area of heterogeneous parenchyma. There is also fat seen with this within. See, but it looks, this is an asymmetry. And if you look for the illustrations, you see, look for the mass. This is a mass, while this, you see the fat is going into the asymmetry, like this.
Yes.
Like this here. The fat is going into. So this is asymmetry, and this, but it looks like a mass. If you do compression view, you might see an underlying mass. Sometimes you might find underlying mass superimposed or obscured by overlying hyperglandular tissue and give you an asymmetry. So do you know which type of asymmetry very close simulating the mass and should be differentiating from the mass?
Yes.
The focal asymmetry.
Focal asymmetry, excellent. The focal asymmetry. Okay. What about this?
But please, Dr. Rabab, can you go back to that case? Because I see it as a mass. Why it is asymmetry, focal asymmetry?
Who is talking?
I'm Sarah Al-Makki.
Ahlan, Sarah.
Yes. For the lesion in the right upper outer quadrant, I see it as a mass. Why it is focal asymmetry?
That this one? This one?
Yes. Yes.
It has no persisting shape, you see? And even if you look here, here it is more full like expanded, okay? And here it is more flattened compared. It has no persisting shape. And you can see the fat is going into the lesions like this, interspersed, going into, and this is also, you see these areas, there is some fat. And if you look here, there is fat here. If you look for this as a convex border, but here it is concave, here it is concave, and here it is straight, not fulfill all the criteria. It's simulating a mass, but it is not a mass. And usually the focal asymmetry is simulating a mass, and we have to differentiate it from
a mass. And this is an ACR case, you see? They report it as an asymmetry, focal asymmetry, not reported as a mass. That is why I brought it exactly to differentiate between they did not describe exactly like this. Just I'm trying to explain for you. But they report it as a focal asymmetry rather than the mass. You see? Their description is focal asymmetry, not a mass. But if you look, the shape is not persisting shape as we described before. And this very small area look like a convex. Otherwise, it has a concave. The mass should not have a concave borders. There is a concave, and you can see part of the tissue going, or that part of fatty tissue going into slightly, not very clear, not in depth, but is going into the borders of the lesions. But this is describing, it should be described as asymmetry, but doesn't preclude that it might be associated with underlying mass. You might do spot magnification, and you might find a mass obscured by the overlying glandular tissue.
Excuse me, Dr. Rabab. How could I differentiate it that is a focal asymmetry or a mass if the mass has irregular shape? If it has an irregular shape, some borders I think will be concave.
Yes, you are right. You are. We have seen before. But if you are in doubt, between is it a mass or asymmetry, label it as focal asymmetry until proven, you see, to be a mass. It fulfills criteria of a mass. You got my point? You got my point?
Yes, I got it. Yes.
Sarah?
Thank you.
Sarah, or not yet?
Yes.
Are you convinced?
Yes, dear. Thank you.
Thank you.
Yes.
Okay.
Thank you.
Okay, what about this? Sarah, since you are there, tell me about this case.
Okay. At the right breast, the whole right breast, there is the global asymmetry.
Excellent,
Yes.
well done.
I can see it at both the CT views and the MRI.
Okay.
So this is a case of global asymmetry.
How you are going to manage the patient?
Yes. Okay.
How you are going to report this case? You are just report this is global asymmetry. So
usually I will ask for ultrasound to see if the second step is ultrasound to see there is any underlying.
If you did not find the patient, just you find this mammogram for reporting.
I don't know. I want to know the history. Maybe she is lactating from one.
You want to know the history. Is really important. Yeah, it's very important. You want to know the history. If the patient is, what do you expect?
For one breast.
What are the questions you would like to ask?
If he is lactating for one breast,
okay,
this can cause this.
Okay, regarding lactations. Okay, what else?
The other thing, if there is any recurrent infection.
Excellent, well done. Okay, what else? What What are the differential diagnoses of global asymmetry?
Other differential include renal failure or heart failure or liver failure.
Okay. But why it is
The other
unilateral?
differential,
Why it is unilateral?
it could be unilateral or bilateral.
In case of unilateral, why unilateral?
Left side heart failure give unilateral more than bilateral. Inflammatory breast cancer also could be unilateral, giving global asymmetry.
Differential
Another
diagnosis.
differential.
Yes, yes. Okay. What else? You are right. Sarah or who is talking?
سهير.
فجأة دخلتي انت في النص. I thought Sarah is because she's taking the case. Yeah.
Okay.
Okay. You are right.
I give the differential.
Renal failure and heart failure, and renal failure, heart failure, liver failure. Give unilateral or bilateral, and inflammatory breast carcinoma give unilateral also. Is another differential.
Okay.
It could be normal variant.
It could be normal variant.
Sarah, you said it could be normal variant. Let us Sarah continue, and then we will open for the rest. Sarah, you said it could be normal variant.
Yes, it could be normal variant.
Excellent, well done.
And okay.
Yes, you're right. It could be. You are right. At the beginning, we said the asymmetry could be a normal variant and could be sign of cancer. So
yes, could be
how we could differentiate, or other diseases, how we could differentiate. And yes, I agree with you. This is global asymmetry. So when I
have to
asymmetry as BIRAD 1 or BIRAD 2 or BIRAD 3 or BIRAD 4 or BIRAD 5. Can be
I have to review the previous mammogram. To review the previous mammogram.
Okay. Excellent. Well done. If the patient has previous mammogram, you have to review it. Okay. It will help. Excellent. Well done. What else? And you said you are going to ask about the clinical, which is important. Yes. Good suggestion. Okay. What else?
I will ask about any history of surgery.
Excellent. Well done. History of surgery. Well done.
Okay.
If you have, if it is not available, you have no previous. You have not the patients, you see, to ask about. You did not find history.
Okay.
So
I will make it as BIRAD 0. I have to recall the patient. Yes. And I cannot diagnose as global asymmetry without any, and I have for further assessment.
Okay. Okay. But I have to consider the other features, Sarah. Is it global asymmetry associated with other ancillary features of cancer or not? Or just a global asymmetry? Yeah, if it, I want to know, is it screening or diagnostic mammography?
Yes, very important.
It's very important. If it is an screening mammography and there is nothing, so I will report it as BIRAD 3. Or maybe 2 if there is nothing. And for screening to be seen in the next screening, if it is screening. But if it is diagnostic, then I will look for any clinical abnormality. So it will be alarming if it will be alarming or worrying if it is associated
with symptoms.
أيوة. Like
Symptoms.
especially if palpable abnormality. Yes. If a palpable abnormality, it will be worrying. I have to go further. Okay, thank you very much, Sarah. Well done. Okay.
Thank you.
Okay. Any other volunteer taking this case? Quickly. There is arrow. You have an arrow. So, and this lesson or this session is talking about asymmetry. So it will be more easy. Is it a mass? This arrow pointing to a mass? Abir, is it pointing to a mass?
I know it's pointing to an area of asymmetry.
Pointing to area of asymmetry. Could you appreciate it in other view?
No.
You could not
I
appreciate.
couldn't appreciate.
So, what do you think?
It's an area of focal asymmetry. So, next step could be a spot magnification view for this area.
Excellent. So I could not see it here, but it might be not included because I don't know if the posterior nipple line is within 1 centimeter or low or not. See, it might be, as you know, there are certain area, okay, can be missed in certain view. What are these areas related to the CC view and what are those related to the MLO? In the MLO, what do you expect the area not to be can be easy missed in MLO?
In MLO, the most medial part of the breast.
Excellent. The most medial superior and superior
part, yes.
The medial part easy to be missed in MLO. And in the CC?
The lateral and the superior part also.
The superior posterior part of the breast is expected to be missed in the CC view, and the most superior part of the breast, even central, might be outside the field of view. So this lesion, it can be an asymmetry just seen on one view or might not be included there. Parents would like to make sure, is it a real or it is, even if I consider it a single view asymmetry, I need to make sure it is real or not. As you mentioned, I'll do here they have done, this is what? This which view?
Exaggerated lateral view.
No, this is not an exaggerated lateral. Look here, this is inframammary fold. So it will be, it looks like the same, but with different angle. So
true lateral.
It is true lateral, straight lateral, 90-degree lateral. So is it seen here, the opacity, this added density, or the asymmetry? Is it visualized here? Or is spreading or different? Is it well shown here?
No, it is spreading now.
It's spreading, and here on the spot
magnification film, it's also spreading.
Spot compression also is spreading away. So no need to go to repeat the CC view to make sure or make extended lateral. From this view and this view, the density is spreading, or the asymmetry is spreading away. So most likely it is just superimposition of fibroglandular tissue, summation artifacts. Okay, it is a summation artifact. So just the patient for screening. This is, and then on the follow-up screening after 2 years, it was not shown, it was not there. So this is just a summation artifact giving us a single view asymmetry. So the most common cause of an asymmetry on screening mammography is normal variations and superimposition of normal breast tissue. We had seen both examples. We had seen the global asymmetry due to normal variations, see, not associated with any other abnormality in screening mammogram. And the other view, the other patient, we have seen superimposition of normal breast tissue causing the summation artifact, which are the most common cause of asymmetry. Frequent finding in screening and diagnostic mammography is asymmetries, and is usually benign. It could represent an island of normal breast tissue, not necessarily summation artifact. Island, it will persist. Island, you will see it even on compression, spot compression view. You will see the tissue is there because it is just an island. You see, surrounding with fat. Okay, island of breast tissue. We'll see example for that. However, as we mentioned before, may indicate a developing mass, architectural distortion, or even underlying cancer. Malignant asymmetry is often subtle and can appear identical to normal fibroglandular tissue. So we have to be cautious. We have to be aware about this. And in one study, nearly half of interval cancer that were visible in retrospective mammography appeared as an asymmetry. So we have to be cautious. And really, it is challenging to differentiate between just an unconcerning asymmetry from suspicious asymmetry. Therefore, to detect early cancer, then we need to pay attention to asymmetries, and it should be considered as significant findings. And therefore, it is required to follow an approach for evaluation of asymmetry. Careful right to left comparison and comparison with previous mammogram, as Sarah said, are vital in this process as well. Supplementary breast imaging should be considered, okay, as Abir said. Okay, what about this? Suhair.
This is craniocaudal and bilateral oblique view, giving a global asymmetry at the left breast, the normal skin.
Excellent. Excellent. The descriptor is global asymmetric. Before you reach global asymmetric, can you describe it for us? Just we are trying to approach.
There is an added density.
Why you said there is global asymmetry?
There is an added density scattered throughout the breast, the left breast.
Okay.
Okay. Not giving the characteristic features of
a mass. Why it is not a mass?
Because it is had no convex border, and the not the criteria for the mass like convex border.
Okay. What else?
Another criteria is I think it has. This is not the mass. It has a shape, three dimensional.
Yes. So lacking the 3-dimension space occupying lesion, and look for the fat in between, interspersed fat in between. You see, this is substantial fibroglandular tissue, okay, occupying more than a quadrant of the left breast, compared having no mirror image in the contralateral. The most important, not associated with presence of mass, not associated with architectural distortion, not associated with
skin thickening or
not
in the
associated with breast or skin edema.
Yes.
So
And
it is
no
just
axillary lymph node enlargement.
yes, this and no axillary lymph node. So it is just a global asymmetry, and in this case, most likely just a normal variation.
This is normal variant, yes.
Yes, so this is illustrations representing a global asymmetry when it is occupying substantial portion of the breast, large volume, greater volume. You see, we call it at least a quadrant, then we call it as a global asymmetry. This is a schematic view, and MLO and CC view demonstrate substantial portion of left breast, of breast tissue occupying the left breast without mirror image correlate in the opposite breast, or no associated suspicious features. Okay, this we described it before as
this is a focal asymmetry.
a focal asymmetry. So this is the focal asymmetry seen in schematic view, you see, and here having it has really more or less similar shape, more or less, and not fitting the criteria of the mass, not fitting the criteria as they describe, not fitting the criteria of the mass in the two standard view. But the more close resembling a mass is a focal asymmetry. Sometimes it is challenging to differentiate the two and then go toward focal asymmetry until proven that it is a mass. And here, I could appreciate an area of asymmetry has no correlate in the MLO. So this it will be, we call it what? Asymmetry.
Asymmetry.
So when we saw the asymmetry in one view, not seen in the other, just we call it as asymmetry. A potential lesion lacking characteristic of a mass seen in a single projection, not seen in the other standard projections. And what about this? This is the illustrations demonstrate what? Asymmetry.
Developing.
Yes, what is developing? Here, compare the two in the illustration and compare the two in the real medullateral mammography. What happened here? The mass or the asymmetry becoming
more appreciated and more conspicuous,
more larger and denser. See here, the density is less than here, as well as the size, so it's getting larger and denser. While in this mammogram, the asymmetry was not seen. So it is a new one. Okay, so a new focal asymmetry or a larger, denser focal asymmetry, we call it as developing asymmetry. So according to Barad lexicons, there are 4 types of asymmetries, which are focal asymmetry, small amount of fibroglandular tissue density over a confined portion of the breast, see, less than a quadrant, visible in more or less similar shape on more than one projection, hence a real abnormal finding rather than superimposition. but sometimes can represent a superimposition. Sometimes, rarely can represent superimposition. This has to be differentiated from a mass. It's simulating a mass, but it lacks the convex border of the mass and usually being interspersed with fat. Not always, usually. You might find it without typical interspersed fat. As that example, you see the fat is very minimal at periphery of the lesion, not seen within the mass itself or the asymmetry, I mean itself. And historically was focal asymmetric density. In the third edition, it was called focal asymmetric density. But now they call it as focal, or since fourth edition is being called as focal asymmetry. Global asymmetry is a large amount of fibroglandular density over a substantial area, at least a quadrant, visible on mostly on two views, but have concave rather than convex border, usually normal variant. Historically was asymmetric breast tissue in the third edition, and they changed it to global asymmetry. While developing asymmetry visible on more than one projection represent focal asymmetry that is new, larger, and more conspicuous compared with previous mammogram. And its positive predictive value is ranging between 13 to 27%, representing BIRAT 4B. It raises moderate degree of suspicion and warranting careful evaluation. So this is the only asymmetry without other associated features. You see, you might need to proceed for a biopsy and further evaluations. While asymmetry is an area of fibroglandular density tissue visible in a single projection. Only one mammographic projection mostly represents summation artifact caused by superimposition of normal fibroglandular breast structures, and historically was density seen in only a single projection. So if you notice, this is called density, and focal asymmetry was called asymmetric density, and global asymmetric breast tissue. So the asymmetry density was referred to asymmetry, and focal asymmetry is no more used. No more use of density. Don't say density, there is density. So we are calling the descriptor now is asymmetry. We have to use the asymmetry as descriptor. Since the fourth edition. Why? Because they use the density as descriptor for the X-ray attenuation characteristic of a mass. And to avoid confusion, they remove it totally from asymmetry descriptions. No more use of density in asymmetry. Either focal asymmetry, focal asymmetry, global asymmetry, or developing asymmetry. Okay, is it clear? Okay. So the differential diagnosis for asymmetry, it might represent any of long list of pathologies. See, it can be with the very common is normal growth variations, asymmetric breast tissue, ectopic breast, accessory breast asymmetry, notice at early puberty or in adolescence. Okay, they presume it might be related to more tissue cells in one side, or one side is a more sensitive to hormones rather than the other sides. Pregnancy also, the effect of hormones might be slightly asymmetric, and during breastfeeding, you know that if at least they favor nursing from one side rather than the others, including juvenile hypertrophy also, post-trauma due to scar, hematoma, or fat necrosis, or asymmetry, residual parenchyma from post-reduction surgery, atypical ductal hyperplasia, sclerosing globular hyperplasia, pseudo-angiomatous stromal hyperplasia, diabetic mastopathy, or even other type of mastitis. You can consider it mastitis other than mastopathy, breast cancer, you see, invasive ductal carcinoma, follicular carcinoma, and tubular carcinoma. These can result in or can be presenting as asymmetry. Okay, what is the asymmetry here? Is obviously seen if you look here. You have an asymmetry, you see, toward the axillary due to accessory breast, okay, not seen in the contralateral. So what is the approach to asymmetry? According to Byratz, we described before the approach for the systemic approach to evaluate the mass. What do you suggest for the evaluation of asymmetry? Sorry.
If it is seen in one projection or two projections, if it is seen in one projection only, we call it asymmetry. And then according to how much of the breast it involves, if it is less than 25%, it will be focal. If it is more than 25%, it's or more than one quadrant, it is global. If I have a previous mammogram and it is newly developed, or it was there but now become more conspicuous or denser or increased in size, we can call it developing asymmetry.
Okay. Any other suggestion? You're right. Do you have any suggestion to approach?
Also, I have to consider the site of the asymmetry.
What?
The site, location.
Location, excellent, well done. You want to know the location of asymmetry. What else?
I think also associated features.
Excellent, associated features. Yes, so how to approach it? First, we would like to define there is asymmetry or something else, or there is no asymmetry, okay? First of all, to define there is asymmetry in this mammography, then what the type of asymmetry is there, as you describe it. Is it asymmetry? Is it focal? Is it developing? Is it global? Any associated calcifications, any associated other features, and the location of asymmetry. See, this is the descriptor regarding the asymmetry. This is our patient, 45-year-old lady presented with left breast lump. This is the mammogram and this is ultrasound. So,
in the mammogram, in the lower part of the breast, the anterior and middle, between the anterior and middle thirds, there is an area of focal asymmetry.
okay.
And there enlarged.
Why you said focal asymmetry?
Asymmetry, just asymmetry. I will call it.
You have only one projection. You have only available is one projection. You will say there is an asymmetry. May you provide me with the other view? Yes. The other view doesn't show this asymmetry. This has no correlate in the other view. So we are dealing with
asymmetry.
We are dealing with asymmetry. Does ultrasound, and because the patient having palpable abnormality, we have to go further. Even if it is seen in a single view, and the patient having palpable abnormality at corresponding location, you have to consider it. You cannot say this is just single view asymmetry and mostly due to summation of tissue, summation artifacts due to overlapping of breast tissue, normal breast tissue. I have to ignore it. No, we have to clarify it. We have to go further. And in this patient, we went for ultrasound and we asked the patient to target the palpable abnormality and we put the probe. Can you see the abnormality?
I can see abnormal breast architecture, which is hypoechoic, an area that does not have a certain shape, hypoechoic area, which is non-parallel to the
this area.
Yes.
Yes. So the parenchyma is tenting. Okay, this is the parenchyma is tenting here, and tethered to the superficial fascia, superficial layer of superficial fascia, and pull it. You see, make some pulling here, some architecture distortion as you mentioned, and this is due to fibrous ridge, and it was stable disappearance, and that is was benign findings. You see, that's just abrasion of normal fibroglandular tissue. Okay, so next patients, quickly. Would like to finish on time. We start late.
This is the mediolateral. This is craniocaudal on the left side and mediolateral. I think mediolateral oblique, but not.
Yes, mediolateral. Yeah, it's not appropriate. It is a mediolateral oblique. You're right.
Yes, and there is a focal asymmetry at the upper out quadrant of the breast. No associated
again. Where?
There is upper outer part of the breast, upper outer quadrant. Yes. At the middle part of the breast.
The middle, but is it outer?
Yes, it is outer.
This is the nipple. Okay. This is more or less central.
Yes.
Central. Upper central. So
representing
at what o'clock? Upper central.
Upper central.
Upper central, and this is which side?
Focal asymmetry.
The side is laterality.
Sorry?
The laterality is right or left? We said localize the lesion by laterality, by quadrant, and and what?
At the middle part of the breast.
The depth, in the middle, yes, you are right. Middle depth.
Yes.
No
associated. No associated.
At what o'clock? 2 o'clock. Clock position.
Yes, this is.
Okay. Continue. Look, Abir and Sarah. You will think that this might have a convex border, but look at how it is elongated here. Yes, it persists a shape. That means there is a shape. So it differs from here and there, but still it has a shape. Here rectangular or here oval or whatever, but there are even the density, the maximum density at the periphery rather than at the center of the lesions. See? So we'll go for focal asymmetry rather than a mass. And next step it will be, I will say, what is next step?
Next
It's
step.
around 12 o'clock might be slightly toward 1 o'clock, between 12 and 1 o'clock, might be 12 and a half. You see? So this is what is next step?
Have to do an ultrasound or spot magnification view.
Yeah, do magnification or compression. Which one?
Compression view to.
What is the difference? What is the difference between compression and magnification? And
to
what?
be sure not an artifact of summation.
So if you don't like to be an artifact, you will do what? Magnification or compression?
Compression.
Compression. We will add more compression, more focalized compression to that area to spread, to make more spread, and to make sure it is a real or not, and to delineate it more to see the morphology of that area. So that is a focal asymmetry, but within which it was a mass.
Yes, it is a speculated mass.
At this level, we'll say this is a focal asymmetry. Okay, and focal asymmetry representing only 1% of screening or in screening mammography, and mostly caused an island of normal breast tissue, as we mentioned. But it can be a true lesion, as in this case. Here it is a true lesion. When we spread it away, we could see just an speculated irregular mass. See?
Dense mass, yeah.
Now, at the beginning, before the spot magnification, we call it as a focal asymmetry. After spot magnification, we can call it as a suspicious mass. Okay.
Yes.
So, approach to asymmetry is define the asymmetry, type of asymmetry as we describe it: asymmetry, global, focal, developing. Go for associated classification, associated features, and then locations. Okay, so the type of asymmetry, we describe the focal, we describe asymmetry. And what about this one?
It could be a developing. Hi, Dr. Rabab.
هنا أهلين.
كويسة.
الحمد لله. الله يسلمك. Why it could be. Be confident and say what did you say? What did you see? So you have
two midulateral and two CC views. For the first one, there is no abnormality. It can be detected. In the other one, there is a small lesion, could be a central or inner border of the right breast. This is considered a developing asymmetry.
Excellent, well done. Is considered as developing asymmetry. So what is next?
The next view, I can see the patient after the next 3 months as BIRAT 3 or to do a compression view.
Okay, let us wait here. Stop here.
Yes.
We said the only asymmetry we have to consider it of reasonable or moderate suspicion without
is evolving. Yes.
Is
with developing asymmetry.
Yeah, so the developing, what is the risk of developing asymmetry?
It could be a malignant, yani.
This is, the risk is much higher. It is, we said BIRAT, it is BIRAT.
It's BIRAT 4B.
It is BIRAT 4B.
Yes.
The other asymmetry, you see, ranging from 2 to 3. You
Yes.
see? And
Yes.
it can be just at the focal asymmetry, it will be 3. And global asymmetry and asymmetry, it can be even 2 if there is nothing, no associated clinical and no associated mammographic suspicious feature. Even you can report it as 2 or even 1. But the developing asymmetry, the only asymmetry, without other associated feature, you should not just say this is an I'm going to follow it. No follow up. You have to clarify. You have to make sure this is a real lesion or not. You see, we have to make sure, is it a real or not real lesion? What is next?
The compression.
Yes, since it's still, even if it is developing, it can be related to just summation artifacts. Or the patient might receive hormones like hormone replacement therapy, and they develop, or the patient might have just abrasions like fibrocystic, like adenosis. It can be benign findings. It can be cyst. So we have to clarify. We have to make sure. We have to make sure what is going on. We cannot say there is no associated features like others, and just we can follow the patients in 6 months or whatever. No. For developing asymmetry, we have to take it cautiously. Okay?
Okay.
So next. Yes.
Yes.
This is a spot magnifications.
Spot magnification. Yeah.
Should it persist or disappear?
It is persist and with
so
area.
It means that is
the mass or lesion.
It is a real. I cannot say mass. Still, it is asymmetry, but it is a real. It is a real abnormality. It is a real abnormality. It is not superimposition of fibroglandular parenchyma. It's real. Okay.
Okay.
So next, next it will be
maybe ultrasound.
Targeted ultrasound, and this is the ultrasound.
Okay.
So demonstrate.
Target ultrasound showed something and
BIRAT on ultrasound BIRAT.
BIRAT 4.
BIRAT 4. Yes, this is BIRAT 4. It's a non-parallel indistinct lesions. Non-parallel indistinct lesion. It is BIRAT 4. So this is malignancy. Seen as developing. Look how they pick cancer too much early.
Yes.
Early. 1 year, you see, after a baseline. That is a baseline showing developing asymmetry in the upper central of the right breast. The spot magnifications, the developing asymmetry, as you describe, it demonstrates speculated mass. But I am not sure. They said they describe this as a speculated mass. But to me, I'll take it as an asymmetry. And after the core and the ultrasound demonstrate an unparalleled mass. After core biopsy, you see, it was invasive cancer. Yes. This we have to pick cancer as early as possible. Like, so if they remove it, as if the patient having no cancer before. will be mostly cured because it is too tiny, it's too small, too early. You see?
Yes.
Okay.
Thank you.
So,
Thank you.
okay. Excellent. Well done. So, the differential diagnosis of developing asymmetries. Still, it can be summation artifacts. It can be fibrocystic. It can be pseudoangiomatous stromal hyperplasia. It can be hormonal replacement therapy. It can be trauma, okay, including surgery. It can be infection, residual post infections, whatever. These are benign differential diagnosis. While malignant, it can be infiltrative ductal, infiltrative lobular, and non-calcified DCIS, or even tubular. You see, these types of usually malignancy can be presenting as asymmetry. Okay, and what about this? Very clear, huh? So again, is obviously seen here. This is the prior, and this is the current. There is a focal asymmetry seen on CC, and MLO of the current mammogram was not shown in the CC and MLO in the prior mammogram. I have to clarify to make sure this is a real lesion, not superimpositions. Spot magnification view, these are spot magnification view, and this spot magnification of true lateral. Since it is true lateral, it still persists, and on compression, أقصد مش spot magnification, spot compression, sorry. Spot compression view is still persisting, and in the compression view of the true lateral is still persisting. That means it is the real, is not a superimposition, is not summation of shadow. Ultrasound demonstrate irregular mass, and it was invasive ductal carcinoma. Without any other associated. This is early cancers. And if you look at it, you might, if you have seen the mammogram for the first time without comparing with the previous, you might pass it, yeah? Do you agree? You might see this
Agree.
is my feet, huh?
Yes.
Huh?
Agree.
Especially it is a screening mammography. It's only screening mammography. So just we have to be aware about these pitfalls and these. Okay, so just reminding, focal asymmetry seen in two projections, global asymmetry seen in two projections. Focal asymmetry represent only 1% or less. Global asymmetry and asymmetry representing 3% of screening. Developing asymmetries is the only asymmetry, okay, raises a reasonable degree or moderate degree of suspicion and require additional evaluation in the absence of history of hormonal therapy, surgery, trauma, or infection at the site. We have to go further, and the asymmetry seen on one projection and also represent 3% of screening mammography. So the commonest are asymmetry and global asymmetry, representing only 3%, while focal asymmetry less than 1%, and rarer, more extremely rare, is a developing asymmetry. However, the developing, the more suspicious type of asymmetries. Okay, and what is going on here? This 50-year-old female presenting for screening, huh? Can you see anything?
Global asymmetry. There is an area of asymmetry involving the inner or central part, inner to central part, and the middle third.
Where?
In the left breast.
Left breast, but left breast where?
in the inner, in the central and inner.
You mean this?
Yes.
Mean this?
Yes.
Concentrate, concentrate. Is it mirror image, CC? Is it a mirror image?
No.
No. So slight variations you expect. Yeah,
yes.
slight. But there is an abnormality. There is something more than this. Yes. Yeah, you expect. Yes, if you compare this area with this area, this is more dense. But this is because non-mirror image. But can you see this area?
Yes.
This is the area of asymmetry. So
yes.
what is next?
I need to see also the other view, the
other.
view.
Can you see it now here?
Yes.
You see, even associated with subtle distortion. There is some distortion is seen with it. This view, due to technical, yani suboptimal, is not well appreciated. It's not an optimum, but it was there. So it is seen in both view. It is.
So it's focal asymmetry.
It is focal. What is next?
The compression, spot compression view.
And if it is seen?
It is.
If it is seen in the spot.
It will be a focal asymmetry. And
so,
real region, then I will go for ultrasound.
Okay. I'll say real abnormality. Why? Because we said if it is parenchymal island, yani it persists as parenchymal island, even in a spot magnification, you might find it as a normal variant. So when I have seen it, it is a real abnormality. But
yes.
is it a pathology or not, this I will go further. So now, if you look here, the distortion is even clear and speculations, and even it looked like a mass here because the center, it is
denser than the periphery.
Dense. See, and there are speculations, and look for the ultrasound. This lady, I remember her. She was around 50 plus. She doesn't like to do the screening mammography, and the primary health care physician was trying to convince her. She came to our department. Yani, someone pushed her. She doesn't like. The technicians came to me. She told me, this lady is not cooperative. She doesn't like that mammography, and I will let her go. I said, no, don't let her go. I went and tried. I spent more than an hour with her, to convince her to do that mammography. You see? And after we finish, I also convinced her to do the spot magnification and to proceed for the ultrasound. And we could appreciate this tiny, you see, cancer. And I called the breast surgeon, and I just, we have no facility of wire localization. We just targeting by ultrasound and drawing. We made a circle around it on the skin, and he removed it for her. And it was just early invasive. I think, I don't remember exactly the grade, but it was too early, sub-centimeter invasive ductal carcinoma.
Subhanallah.
Yes. And there was no any other changes. You see, look, it was about maximum even 6 millimeter. It was a 6 millimeter invasive cancer. But here on ultrasound, yes, on mammography, it is suspicious as a mass on the spot magnification only, not on the standard view. Here the center, look for the center Abir. Look for these spicules, and the center is dense. So this is a mass, speculated mass. And if you look for ultrasound, there is cutting sign. You remember, do you remember the cutting sign? There is, so it is tiny, but there was definite cutting sign. I reported as Barat 5 because of the cutting signs. See? And here, because the center is dense. So reported as Barat 5, and it was proven inverted cancer on a screening mammography. Okay? So it was inverted carcinoma. At the beginning, it was focal asymmetry. Okay. This is a case from literature. Quickly. We want to go through many examples.
Dr. Rabab, for the previous patient, the first image.
Here?
Yes, yes. The right breast. What about the hypodense in the upper?
This?
I can consider this normal variant, or yes?
This area?
Is asymmetry?
No, this is fat lobule. You see? This is the patient was not cooperative. That is why her mammography was not an optimum one. I told you, yani, she doesn't like to do that mammogram since the beginning. From the clinic, the physician pushing her. And when she came, yani, she was hesitating to do the study. And very uncooperative. And I spent long time convincing her to do that study. I remember that patient. It's since 2014, but I remember as if today. See? Because yani, after her physician convincing her, and I convinced her, and we found 2 tiny malignancies. That is why I could remember her. See, look for the area, very subtle area, and here you see that is the area of distortion with difficulty, and I was attending with her that spot magnification view. She doesn't like the technicians. She doesn't allow the technician to do that for her. You see, and with difficulty, I could convince her to do the spot magnifications to clarify that area. When I have seen the central high density region, I suspect that this is a malignancy. I took her to target the same area, and it was difficult, was non-palpable. You see, just she came for a screening, not palpable area. And I was searching, and she doesn't like the study. So that is why I remember sometimes you might be faced by this type of difficult patients. And she was lucky that she had a very subcentimetric, small subcentimeter cancer. That is why I was happy, and up to date I am happy that I could convince her to save her life with this screening study. Okay. What about this? This from the literature. It's not my case. Abir? Who's talking?
Hannah.
Hannah.
Yeah. This dense breast first.
Excellent, yes.
Dense breast. There is an area of central asymmetry.
Where? Start by laterality. right, left. Then describe further.
In the right breast.
In the right breast, huh? You are talking about these calcifications?
No,
huh?
no. Outer. There is
outer here.
No. Inner central. Inner central.
Here.
Yes. Yes.
It's okay. Accept
This lesion.
This accept. It's okay.
Yeah. However, it cannot be well
appreciated.
seen on
No other
appreciated.
larger. If I tell you normality in the other side. Would you please mute your phone, your microphone? Continue, Hannah.
Yes, it will not well appreciated on the midulateral view.
Nothing in the left breast. Let me guide you.
Yes.
Anything in the left breast?
The left breast on the outer, there is a focal asymmetry. Large.
Okay.
How
this area?
Yes.
Yes, excellent. Yes, there is area of asymmetry seen on the outer CC view. Could you appreciate it in the MLO?
No.
Okay, what is next?
The next is compression view.
Okay, spot compression view.
Yes.
Okay, it was there. That is the one, but faintly seen. That is why reported as focal asymmetry. Okay, that is the spot. Sorry, it came here.
Yes.
Wait. So
on compression view, reveal and mass with an
excellent.
ill-defined margins.
Wait, let me ask you questions.
Yes.
If you could not appreciate it at all in the MLO, if I did not say for you it is seen MLO, what would be the next step?
The next step will be an ultrasound.
Why not? It is very clear there, so you can do spot magnification still.
Yes.
It is very impressive area of asymmetry, even if it is asymmetry seen in in this dense breast. I have to proceed for the spot magnifications, and on spot magnification now it is seen as
a mass with an
irregular. Yes, it is a mass.
Irregular margins and
irregular. Is it irregular or indistinct or obscured or masked?
Area. There is the outer area is obscured. However,
yes.
The
so
inner
this is circumscribed, while more than 70% is obscured. So yes. So mass. This is obscured mass. What else? What else? More description. Yes. Is circumscribed, partially obscured mass or mask. I can say mask. Okay.
Yes. There is an faint microcalcification.
Associated microcalcification. How you can describe this microcalcification? Do you know?
More amorphous.
Excellent, well done. It's an amorphous. is an amorphous microcalcifications. Okay. Okay. So based on this spot on mammography, you are going with that before going for ultrasound. You will report it as you are going to report as BIRAT.
BIRAT 5. I will put it as 5. Yes.
Okay. Why 5?
Because the irregularity or indistinct mass with an associated amorphous calcification.
Yes. Okay. So the indistinct margins, we said it is BIRAT 4. Yeah, before.
Yes.
We said it is BIRAT 4. B.
No.
Or C.
Yeah.
B or C.
ما قلنا B if 4B if asymmetry.
No, we are talking about the mass. We said speculated is BIRAT 5. Speculated is BIRAT 5, but indistinct and microlobulated are BIRAT 4. BIRAT 4. BIRAT 4B. Microlobulated less suspicious than indistinct. Indistinct is 44% positive predictive value. So still it is BIRAT 4B. So if you are talking about the indistinct, it will be BIRAT 4B. If you add the microcalcifications, the microcalcification is not polymorphic, it is amorphous. So
yes,
BIRAT 4. I agree with you. If I'll upgrade it, it will be BIRAT 4C. To me, I am going to report as BIRAT 4C. It's okay. So what is next?
The ultrasound.
Why ultrasound? Why you are going to do ultrasound?
To try to confirm this mass, architecture.
To confirm it is a mass, even if you do not it is a mass. But you need to characterize it further, even either upgrade or downgrade it, and to localize it for
biopsy.
For biopsy. So what about the ultrasound?
Ultrasound shows a mass with an area of irregularity and indistinct laterally, and it's appear a little bit heterogeneously. And there is an area of calcification also appear in ultrasound.
I agree with you. This is a deceiving. See, this lesion is really deceiving, but it is there. Any more suggestion? All of you, do you agree about this is upgrading? Or, any other suggestion regarding this mass based on ultrasound?
Based on ultrasound, I can put اسمه شنو هو كان؟
Is it indistinct on ultrasound, this mass? Okay, if you said this area is indistinct, I cannot I cannot 100% or guarantee it is indistinct, because this is it is not at the center of the probe. I need to angulate and to see these areas, you see, with different angulations. I have to see it with different angulations.
Yes, other things like big like that.
I can see mostly circumscribe the mass, mostly. But I agree with you, the mass is throughout studied with microclassification, and there are tiny cystic changes. So
I can put a phylloid as a
there is no
differential.
posterior shadowing. There is indifference, posterior acoustic features, but only edge, this edge shadowing. This even obscuring this border, the edge shadowing obscure this lateral aspect, medial and lateral aspect of the mass. So the time pass, yalla.
So I will consider the biopsy.
Biopsy, yeah, agree with you. I'll consider biopsy. But do you suggest any diagnosis? Yes,
phylloids. Can I say phylloids?
Yes, phylloid is accepted. What else? If it is not phylloid, yes. Yes, you are right. Do you know
fibroadenoma?
Do you know
Fibroadenoma. Fibroadenoma.
Which fibroadenoma? Which type of fibroadenoma?
Atypical.
Not
Atypical one.
Specific name, specific characters of fibroadenoma. If it contain cystic changes, fibroadenoma, and microclassification, so we call it complex fibroadenoma. Okay.
Okay.
So ultrasound show circumscribed. This is circumscribed. Yes, here it is not clear. Agree, but there is this border is circumscribed, partially obscured. And I accept if you told me indistinct, I'll pass it. But on ultrasound, no. On ultrasound, these are the surrounding fibroglandular tissue. And the mass is sharply demarcated. And it is parallel, sharply demarcated. You see, and this edge shadow. All are characters going with probably benign, except for this studied microclassification and tiny cystic changes, raising the speckles of microclassifications and cystic changes, raising complex fibroadenoma. And then if even this is complex fibroadenoma, it has to be biopsied. Okay, and the diagnosis was concordant. Okay, so focal asymmetry seen on two projections. It is real findings caused by an island of normal tissue, no associated distortion, speculation, or significant classification. Then we'll say it just an island of breast tissue. Or it can be a true lesion, as in this case. It was a focal asymmetry representing underlying fibroadenoma, obscured because the breast is dense. When to worry about focal asymmetry, if it corresponding abnormality, okay, if there is lack of specific benign characters. So it warrants further evaluation and should be considered suspicious if it is denser at the center. So suspecting that might represent a mass. If it is associated with breast erythema or edema or architectural distortion or calcification, then additional evaluation are required. Spot compression or different angle mammographic viewing can be helpful. Okay, so this is an example of
focal asymmetry.
It is focal asymmetry. It is small, seen in both projections, persistently seen on spot compression. So it is real. It is there. It is not superimposition, summation artifact, or superimposition of fibroglandular tissue, but it is seen in spot magnification and seen on ultrasound not as a mass, as just a focal area of breast tissue, island of normal tissue. Now you understand difference between superimposition of tissue and island of breast tissue. We said the focal asymmetry is a real. Real, it doesn't mean that. Real, it means not superimposition of parenchyma. Okay? But still it can be just a normal parenchyma, like an island of parenchyma. This is an island because it is surrounding by fat from here and here, and this is only area of fibroglandular parenchyma looking like a mass. Okay? But if you look within, there is area of fat. See? Within that area. And if you look for the borders are concave rather than convex. Okay. And if you look here, what is this? There are arrows representing what?
Areas of focal asymmetries.
Excellent.
At the
well
right
done.
breast.
Who's talking?
I'm Sarah.
Hello, Sarah. Ahleen. Yes, these are what I brought this image. Okay. Why this case? To know that the focal asymmetry can be multiple. See, not necessarily to be one. These are multiple areas of focal asymmetries. But why we said focal asymmetries are not fulfill the criteria of radiodense mass.
Typical mass.
Typical mass. Are not associated with any other suspicious features. See? No suspicious features. And it was reported as BIRAT 3. And on follow-up, so it was stable. Then it will be reported as BIRAT 2. If the densities are stable, you see, for 2 years or more, in this case, it was stable for 4 years. So consider to be BIRAT 2. But at the beginning, in the baseline, if you see it like this, and no other associated features, you are going to report it after you do spot compression and you can do ultrasound and you could find no abnormality, you report it as BIRAT 3. BIRAT 3. See? Then on follow-up, you are going, if it's stable, it will be BIRAT 2. So this is my patient. 37-year-old lady presented with right breast lump. She has palpable abnormality. So, what is the abnormality?
Yes, there is an area of focal. There is an area of focal asymmetry noted at the right upper outer quadrant mid breast.
Okay. Excellent. Excellent.
Okay. No associated calcifications or inassociated features.
Excellent.
There is multiple lymph node. I could identify the hilum within these nodes. For me, they are suspicious.
Who is talking?
I need to do
Who is talking,
compression.
Sarah or whom? Who's talking?
Sarah, أيوة. Sarah.
Okay.
Sarah,
Sarah, axillary lymph nodes are one of the associated features. Since you said
yes.
no associated features, and then again you said there is associated adenopathy, and there is contradictions here, okay? But lymph nodes are considered one of the associated features.
No associated. Okay. Okay.
So
it will be there is focal asymmetry with no associated calcification, but there is associated lymphadenopathy.
Okay. So
next step, I want to do spot compression for this lesion. for this area.
Okay.
So it persists. And
okay.
It's a real focal asymmetry. So
Yes.
I will do targeting ultrasound.
So it is real focal asymmetry. I'll go for ultrasound. This is ultrasound.
For me, the ultrasound showed multiple cystic areas of different sizes.
Yes,
corresponding with
different
focal
angles.
fibrocystic.
This is the same but different angles, you see.
Yes, areas of focal fibrocystic change.
Yes. Yes, this is area clusters of variable size cyst, okay, causing a mass-like, but no associated any suspicious features. Okay,
Yes.
and biopsy was reported as para 3, but optional. I don't know, related to the physicians or the patient concern or whatever. Biopsy had been done and it was the fibrocystic, proven to be fibrocystic. Okay? So asymmetry, we describe focal asymmetry can be caused by fibrocystic. Okay, this is the same patient. This is the focal asymmetry. And if you set the global asymmetry, it's also accepted. And it's a little bit large. It can be focal, it can be global. And it is borderline in between. Okay, so it was a fibrocystic. I don't know why it's been repeated. Okay, another patient.
Okay. There is an area of global asymmetry affecting the left breast.
Excellent.
It is associated with skin thickening and trabeculations. And
trabeculation, what?
A thickening of the trabeculae.
Thickening of the trabeculae. And?
The nipple, even the nipple, I think it's somewhat, yeah. The skin thickening and trabeculation are obvious. So this global asymmetry, since it is also, and there is
reflecting what? This reflecting what?
Reflecting edema.
What other sign in this image demonstrate breast edema? Or the edema extending to where?
I can see other pathology, but I don't know if it is breast edema. Yani I can see that the pectoralis major muscle is not has no clear outline from
excellent, well done. So the edema is extending to the prepectoral regions. When you see breast edema extending to the prepectoral region, you see it is significant, and it gives even the significance give a little bit more suspicion. And also, if you look, there is increased vascularity. Compare the two sides. Look for the vascularity.
Yes.
There is increased vascularity and there is diffuse. So we are dealing with
malignant, I think.
Suspicion. Yes. I will go for BIRAT.
But at least for.
It is BIRAT.
With associated features.
It is BIRAT 4C. You see, because it can be mastitis. You cannot guarantee. It can be mastitis. Yani, the lymph nodes, the only feature, the prepectoral edema, make it a little bit more suspicious. And even here, some distortions. The edema and subtle distortion making the pectoralis not very clear. But still, if there is infections, a lot of infections, and the whole breast is involved, you see, might be. But these features are suspicious. So, what is next? In this case, it will be
ultrasound.
Yes, yes. I haven't seen a specific area to target it by magnification view, or I'll go for ultrasound, and if ultrasound doesn't show abnormality, I will go for
MRI.
MRI. But this patient, they had done
PET scan.
Yes, so demonstrate.
Please uptake at the left breast. This is normal.
This is skull. So this and having metastasis. So this patient now, it is cancer. So what are the differential diagnoses for global asymmetry? We described it before.
Yes, either malignancy.
Commonly, it is due to
variant, normal variant. If it is
normal variant is common. That's okay. But it can be,
it can be inflammatory
carcinoma. It's okay.
Invasive carcinoma and post-radiation.
Okay. Post-treatment, yes, excellent. Post-treatment, post-surgery, post-radiation, yes. Can be.
Causes of generalized edema, like cardiac or renal.
Systemic causes, okay. What else?
We say just inflammatory, not inflammatory carcinoma, but any inflammatory condition.
Yes, benign inflammations like mastitis. Let me ask you one question. If you have enlarged breast with global asymmetry, and if you have small breast, the global asymmetry is the breast associated with global asymmetry is smaller compared to the contralateral breast. Which one you can make it suspicious? You can report it as suspicious, or you will raise the suspicion. The enlarged breast or the smaller breast? This one doesn't show significant enlargement, more or less same size, but giving these edematous changes. But you might see, you might show, or you might see a breast global asymmetry associated with enlarged ipsilateral breast, and the other patients global asymmetry associated with smaller breast. Which one is suspicious?
Yeah. The enlarged one.
The enlarged one. Okay. Why confidently you said the enlarged one?
This means it's not a normal variant. There is additional pathology.
And if it is a smaller, global asymmetry and smaller compared to the other one, so it will be a variant. Why it is small? Any suggestion? Do you agree?
I think the smaller one, I disagree. The smaller one usually more suspicious. Because usually the inflammatory carcinoma, the patient presented with a smaller breast. Yes, there is infiltration of the lymphatic of the breast, overall breast. Yes, shrinking of the size of the breast.
Yes, this here, this the infiltration of lymphatics in this, causing the trabeculations and the prepectoral. This area is rich in lymphatics also, giving this edema here. But what is the name for the small breast with suspicious features? We call it what would we call it? what will happen for the breast if it become infiltrated by malignancy? It
Usually
might.
the skin change orange skin.
It
The
will
red orange
shrunken.
skin.
Excellent. Who said that? Abir?
I said
The
it
bed
will
orange.
get shrunken.
Who said shrunken?
Abir, yes. Abir al-Hadi.
Yes. 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 We said
As it
global.
infiltrates the...
Be with me, Dr. Sarah. You are right. Normal variations, you see, we said global asymmetry, commonly or most commonly to be normal variations, can be related to the surgery. Okay, reduction of to the opposite breast, can be pseudoangiomatous stromal hyperplasia, can be infection, mastitis, and can be malignant. Okay, and it become worrisome if associated with palpable abnormality. And if it is associated with palpable abnormality only, okay, and no suspicious mammographic finding, then it will be by RAT4A. The probability of malignancy will be about 8%. And if it is associated with erythema or edema, okay, then it can be inflammatory cancer or mastitis. If it is associated with architectural distortion or calcification, it becomes more worrisome. And one of the differential diagnoses, when it gets smaller and denser, we call it shrinking breast. And they said this is associated with invasive lobular carcinoma. See? Yani, the infiltrative breast, it can be enlarged or it can be shrinkage. And if you remember, previously I have shown to you for the asymmetry, one of the lectures, I don't remember the second lecture might be, I have shown to you one case of this shrinking breast, see, with malignancy. Okay, next patient. Time pass quickly. This is straight now, by now, I need from you just even without telling me where exactly. Give me just, there is asymmetry or not, approach, asymmetry or no, and what type of asymmetry. Okay. And if it
This
is
is
associated with other, that is it.
This is an area of developing asymmetry at the left breast, upper part
yes.
of the left breast.
Upper, this is, what is the view? What is this view? It's a CC view. So you are dealing.
This is a
this is CC view.
lateral.
Yes, screening.
Lateral part of the breast.
Screening. This is screening. So that is the previous. And current, this is, you said
developing asymmetry.
Developing asymmetry. What do you want?
You have to see the other mediolateral oblique.
Okay.
And confirm it. It is a focal asymmetry.
Yes.
Developing focal asymmetry.
In spite, it looks like a mass. It is a mass. It is obvious it has convex border densities. So, but it is on interval. That is why we call it a developing asymmetry. You got it?
Yes.
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 It is a mass. It looks like a mass, but I'm not going to report
yes.
it. I will report it as developing asymmetry and I will work it out. You see? And it was invasive ductal carcinoma in this case. Okay?
Yes.
That is the mass you see in two projections. The lesions, I mean. And this is on ultrasound. It was invasive cancer. Irregular, rounded, indistinct mass. Okay, indistinct rounded mass, and it was invasive carcinoma. Okay, so to remind you again, asymmetry focal, two projection, global, two projections, developing. Remember, the moderate suspicions require further evaluations, and the asymmetry seen on one projections. Okay, so the approach, type asymmetry, associated, classification associated, features and locations. Okay, this is our patients. She had left breast lump. Okay, quickly. So
there is an area of asymmetry at the lower part of the left breast.
Excellent. Yeah.
No
There is
associated.
area,
No associated skin thickening or retraction, nipple retraction, or architecture distortion or axillary lymph node. I have to see the craniocaudal view to confirm it is a focal
I don't
asymmetry.
accept. I don't accept from you. Why? And you will tell me there is suggestion. If I'm going to report this case, I'll say there is suggestion of focal asymmetry. And I will stop here. Why? Why I'm going to stop?
Asymmetry because it is one view.
عشان التكنيك ما مظبوط.
Excellent. Well done, Magdalene. Because this is not an optimum mammography. Even this asymmetry can be related to
malposition.
Malposition. This is not a good mammography to comment on. I'll say there is suggestion of focal asymmetry. I'll try to correlate if it is the same location of the patient's palpable abnormality or not. Might be yes, might be not. I cannot say there is no, and there is no obvious. I might say no obvious calcification, no obvious, but I cannot confidently say there is no. I cannot exclude everything based on this suboptimal mammogram.
Okay.
Do you agree?
I agree.
We spent how many hours talking about the quality?
Yes.
This is very essential. You see? Okay, this suboptimal mammography, and might be the patient refused or whatever, or I brought it for that reason. Okay, this is the other view.
Yes, on craniocaudal view, it's seen as focal asymmetry.
Yes. So the suspected asymmetry on the MLO is being confirmed. It has a correlate on the CC view. Where on the CC view?
At the inner part of the breast, of the left breast.
In the inner, or in the medial aspect of the mid left breast. So
yes.
So next,
this is a focal asymmetry.
It's a focal asymmetry. So either I'll do compression, and if the patient refuses, no need for compression. If the patient refuses, I'll proceed for ultrasound. Since there is palpable abnormality, and that was ultrasound. This is my patient. She has invasive cancer, okay?
Yes.
Yeah. Okay. Okay. Next. Who will take this patient? Quickly. We already we complete the 2 hours. Would you like to proceed?
Me, I will proceed. I am Dr. Sarah. This is the CC view. There is a right breast global asymmetry.
Excellent.
Yes. No other associated microcalcification.
سارة الماك.
سارة بن عوف.
سارة بن عوف أهلا بك.
هلا. If any other, this is mediolateral projection. If any other projection.
Okay, there is no other projections.
I will, like such patient, I proceed for ultrasound.
You will proceed for ultrasound, but I don't agree with you for one point. This CC view is what? Is it an optimum? Is it an optimum mammography?
Not optimum mammography.
In terms of what?
The posterior.
Okay. Regardless of inclusions of breast tissue, I'm not talking about the inclusions. Regarding the other factor, do you remember the 8 criteria of quality, mammographic quality?
Yes.
So, is the image, the exposure and compression is good and these things? Yeah, the positioning is not bad, but the contrast,
the compression.
I
think the compression on the right side not adequate compression.
Not adequate. That is why the image is also hazy. The
Yes,
separations, if you look for the left a little bit, though is not also optimum, but under exposure I could not see, or overexposure I could not see the skin. I don't know. There is something wrong regarding the exposure, but the right one is even hazy. So it's not an optimum. Yeah?
Yes. Yes.
That is why I cannot comment on microcalcification on this one. See?
Okay.
Yeah, I don't know. I can see some densities here. I'm not sure. I'm not sure about these densities.
True calcification or no? Yes.
Might be. I am expecting these to be calcifications, extensive calcification. But I am not going to exclude it, and I'm not going to mention it. I will say not suboptimal. The only abnormality I could appreciate is extensive global asymmetry.
Yes.
I need to proceed. And if I told you the patient have palpable abnormality, so it will be.
Next step, like this patient, I will do this compression for this such patient.
Yeah, you can. If the compression for the whole breast, the patient might not tolerate, or maybe the breast is swollen or something, might be difficult to do more compression.
Yes.
This is just you might repeat or to look for the other view for the for this associated, if there is associated distortion or microcalcification. Yeah, what is your differential diagnosis?
If this there is palpable clinically there is palpable mass, this is one of the worrying signs.
Yes.
Then my differential diagnosis, there is benign and there is malignant. I will suspect like a ductal cell carcinoma.
Excellent, excellent.
And also there is global, maybe there is also mastitis.
Mastitis, excellent.
Yes.
It can be mastitis. Yes, you are right.
Or
if I tell
hormonal therapy.
If I told you these are microcalcifications,
I will think of this ductal invasive ductal carcinoma.
Invasive or other types. If there is microcalcification.
Ductal, yes. Ductal or lobular. Or DCIS?
DCIS, yes. When you have seen extensive
carcinoma in situ.
DCIS plus or minus invasive. You see, it might be associated this global asymmetry due to extensive
Ductal carcinoma in situ.
So just put on your mind the differential diagnosis. I tried to bring a lot of differential just to remember that there are many differential diagnoses. So we have to tackle the patients properly, not to ignore things. Okay. So what is the focal asymmetry here? There is carcinoma and there is focal asymmetry. I forget to remove this. So it came. So where is that? Where is that? What is the findings?
Upper lateral.
Upper lateral. Seen as? Yes. Yes. That is the lesions. See? This is the lesions here. What is next step?
Compression, spot compression view.
Okay, so this is spot compression. So
it's an indistinct mass.
Indistinct speculated mass. So it is Barat 5 because it is speculated. Okay. So again, let us go for the associated features. Okay. So this is, can you see it?
Yeah, developing asymmetry.
Excellent, developing asymmetries and associated with what?
Articular distortion.
Distortion and
microcalcification.
Calcification. These are associated with calcification. Okay, so this is 51-year-old postmenopausal woman, hormonal replacement therapy. This is my patient. Can you see an abnormality here? Quickly. Time.
Yes, I can. Hi, Dr. Rabab. I can see a small dense lesion in the outer part of the breast.
Dense lesions. For us, we said either a mass descriptor or asymmetry. So you are talking about a mass or asymmetry?
For me, it's a mass.
Where?
And the outer
This is MLO. This is MLO. I don't know. It is CC. It is a CC. Yes, agree. It is a CC. So in the outer here,
yes.
Where is the mass? Where is the mass? This is a mass?
No. Small, very small. Very small.
Here?
Yes.
This one?
Yes.
Okay. Other suggestion? No, this is not the one. Look,
yes.
Look carefully. Look carefully. You can see it, huh?
Okay, I see an asymmetry
Sarah?
at the central midbrain. Yes.
Sarah?
Yes,
Sarah
Sarah.
now for Sarah Al-Mak?
At the Sarah Al-Mak.
Ala Sarah, huh? You can see?
At the central breast, posteriorly.
Here? Here?
Yes, this area.
This area?
Yes.
Okay. This is normal glandular tissue.
There is another one at the center mid breast.
Excellent, well done. You are talking about this area.
Yes.
Yes, you are right. You got it. This is the area of asymmetry. So to confirm it.
So yes, I need to see the other
view. It is there.
View. Then after that, I
It
will
was
ask for
there.
compression.
It was
Spot
there.
compression.
I'll go for.
Yes.
So it was there. I will report it as bar 0. I don't know. Dense pressed, and I need to go further. Okay. Now this is the spot compression.
Okay. So it is true asymmetry with associated.
Excellent. Well done, Sarah. Why you said focal asymmetry?
Microcalcifications.
Why you said focal asymmetry? Why you did not say speculated mass?
Okay.
Excellent.
I don't know the density.
Because
the density it is not
the previous example, when we do the spot, the case of hint, it was clearly reported as a mass. But this, you are 100% correct. It is a focal asymmetry. I'll not report it as a mass. Why?
Because it is not denser at the center. It's denser
That's
at
excellent.
periphery.
Yes, it is speculated, associated with distortion, but the center is not dense. It is dense at periphery rather than the center. So this is not fulfilling the criteria, at least at this table, is not fulfilling the criteria of radiodense mass. So I'm dealing with satellite lesion, focal area of distortion, asymmetry with distortion, and microcalcifications. Now it is associated, so it will be BIRAT.
Okay, I think this is BIRAT 5 with speculated and like that.
Well, why you go for 5?
At least BIRAT 4C.
It is BIRAT 4C. Why it is not 5? Why not 5? Because we are not dealing with a mass. If it is speculated mass, yes, I'll go for 5. But I'm dealing with focal asymmetry with distortion and calcification. So, what is your differential diagnosis? What could it be? It could be.
Okay.
It could be what? Your differential. If it is malignant, it could be. If it is benign, could be.
Okay. If it is malignant, I would think of DCIS. Okay.
Or DCIS or right. It can be DCIS. It can be. It can be.
Lobular carcinoma also present with.
Can be lobular, can be ductal, it can be tubular. It's okay. This is if it is malignant. If it is benign,
yes.
If it is benign, it can be
benign, maybe dash.
Would be a focal glandular tissue.
You mean island of parenchymal tissue, but there is distortion. Why it is distorted? Why it is distorted and why it is calcified? So there is pathology. There is a pathology here, but this pathology, it can be benign, it can be malignant. If it is mass, I will say no. This is BIRAT 5. But since it is not a mass, I will say this is BIRAT 4C. Since there is suspicious calcifications, suspicious, and even the calcification is, I could not characterize it well. I cannot say suspicious, but I can say yes, there is amorphous calcification and there is distortion. So I'll go for BIRAT 4C for biopsy. But put in your mind, if it is, what is your differential if it is benign?
Maybe just sort of sclerosing.
The differential.
Yes. Sarah, huh?
Yes.
Sclerosing.
Sclerosing adenitis or adenosis.
Excellent. Complex sclerosing lesion. Excellent. This is
Sclerosing
can be a sclerosing adenosis. Okay, complex sclerosis.
Another benign differential also include radial scar.
Yes, radial scar is one of the complex sclerosing. Complex sclerosing lesion can be sclerosing adenosis or radial scar. You are right, 100%. Excellent. Yeah, both are differential diagnosis. Excellent. What else?
Focal fibrocystic once she on hormonal therapy.
Excellent. Hormonal therapy. Yeah. What else? Strobal fibrosis can be also. Okay. That is the ultrasound. So that was ultrasound.
Accurate. In the ultrasound, okay. There is a small speculated L5 lesion with cutting sign. I can see. Yes, this is highly suspicious. This is pyrite 5 with posterior shadowing.
I cannot say. You see, this is deceiving. This here, because you have shadowing, you have posterior shadowing. It gives you apparent cutting signs.
Okay.
And this, you see, there is, it's going here, extending beyond this area. Not definite. Yes, speculated, yes. Vertical oriented, yes, but no definite cutting signs. Still, it is Birat 4C. See, still it is Birat 4C. It's suspicious, and the diagnosis was a radial scar. So, what about radial scar?
Okay.
Do you suspect about? Yani, what is the management for radial scar? What do you know about it? Okay, I'll leave it for the next session. Prepare about it and tell us about radial scar at the beginning of the session. Okay? Okay. Let us go for the next case. Suhair.
Yes, this is craniocaudal.
Medina is not available today. I did not hear her voice at all. Continue.
This is craniocaudal.
Suhair.
Sorry. This is craniocaudal of both breast, showing global asymmetry at the left breast with associated skin thickening. I would like to see the mediolateral oblique and to ask about the history of the patient.
Skin thickening.
Yes.
If I remember this patient just screening, and she has no palpable abnormality and she has nothing, and that I think it was persisting unchanged since the previous study. So
could be normal variant. Normal variant.
So it was a normal variant. This is normal fibroglandular. See? Variations between the two sides. Okay? What about this one? Continue.
This is the left breast show global asymmetry and thickening trabeculation and skin thickening of the whole skin. Global skin thickening.
And
nipple retraction.
Excellent. Nipple retraction. So this is
highly suspicious of malignancy.
This is highly suspicious of malignancy. Okay?
Yes.
Sorry, it came normal, not a normal, by mistakes. Let me. It is global asymmetry only, and it was a cancer.
Yes.
In a case of malignancy. This is my patient.
Yes, no problem.
Malignancy.
but it is not. It is not. I don't. It was not. It was not. It was not inflammatory carcinoma. I think, if I remember, lobular or something. Okay. So
Okay.
regarding
Regarding 4 or 5.
so regarding the previous, just regarding the associated
Yes.
features. Continue.
This is craniocaudal. On the left craniocaudal.
Okay.
No, this is two view of craniocaudal view. Craniocaudal. I'm
Only
seeing
craniocaudal. Mediolateral and craniocaudal. This is suboptimal positioning. See, the breast, when the breast is edematous, expected to have a problem in the positioning. Because the patient will rate the compression and positioning. Okay. So
demonstrate asymmetry at the lateral part of the breast with associated architecture distortion and skin thickening, nipple retraction.
Okay.
So this is
you are saying you describe it as
in craniocaudal. I describe it as speculated mass because it is obvious has spicules.
So this can be distortions.
Yes.
Depends.
You have to.
It depends. You might say this is the mass. You might say this is the mass. But if you look for this, what about this? This is part of the mass. This is part of the mass. All are abnormal. This is area. But it looks like يعني multifocals. You see, multifocal asymmetry.
Yes.
Or global asymmetries. Okay. And even if you look here, there is another area of, I will go for multifocal associated with distortions. So this might be part larger focal focal asymmetry, and the others are this another foci. But multifocal asymmetry, okay, associated with distortion and diffuse breast edema and the skin edema, more around the areolar skin with nipple retractions. So I'll go for BIRAT
5.
This I'll go for BIRAT 5, obviously. So these are associated features. I'll go for, yes, here I put it at global asymmetry, but yes, it can be global asymmetry accepted, can be multifocal asymmetry accepted, and the patient was invasive ductal carcinoma. Okay, these are associated features, and yes, it is BIRAT 5. And what about this one?
This is, I think, craniocaudal view. Craniocaudal show global asymmetry with associated edema, breast edema, and skin thickening, nipple retraction, and architectural distortion.
Yes.
Also represent BIRAT 5.
I think this is lobular carcinoma, if I remember the patients. Look. So ultrasound demonstrate underlying mass. See? Demonstrate it. But if you go back, you see that is the area, I think so. But even here, even there, this all it looks like it is a global asymmetry. The global asymmetry. Okay, and what about this?
Continue or another one?
Another volunteer. Any other participant? Quickly, the time passing very quickly. Let us finish.
At this right CC view, I see edematous change in form of skin thickening.
Yes.
Thickening trabeculae.
Okay, excellent. Well done.
I couldn't see underlying mass or suspicious calcifications. These are benign type of calcifications.
Yes, excellent. So, so this,
For me, this is a breast edema.
Excellent.
So
It's breast edema. I'll
Mm.
sort it
Just a
out.
stage.
I'll
Mm.
sort it out looking for the cause of breast edema. Okay. So, if I'll tell you this patient is around late 40s.
Okay.
So what?
Any other? Okay.
Her age is late 40s, not even complete. Yes. So?
Okay. I need to do an ultrasound type. Before that, I have to go deep in history. Any fever to suggest inflammatory mastitis, or
No.
if there is no.
No.
Okay, so I have to sort out inflammatory type of carcinoma.
This edema is more than 3 months. Is it still inflammatory carcinoma?
It could be more than 3 months.
Not progressing. It could be more than 3 months. Edema, non-progressing inflammatory carcinoma. You are going, Sarah, you are going to prepare the inflammatory carcinoma. Another homework.
Okay, another.
Huh? I gave you clue, but you didn't use it.
Yes, you said late 40s.
Yes, and so what about the patient age? Is she old?
She's
not
old.
Not reach 50. So
still she is premenopausal.
She is not diabetic. She is not diabetic. She's young age, not diabetic.
Okay. Can we just follow mastitis?
Any history of renal problem, cardiac problem?
Excellent, well done. Why you ask about this?
Because 3 months is a long time to be non-progressive. It should
But
find
the clue in the sentence I have told you, the
calcification is not common at this age.
Yes, Sarah. I was pushing you for the calcification. Why this patient, she has a calcification? She's still young. She's not diabetic and she's still young. Why she has a calcification? So this vascular calcification is a clue. So she has, this is the cause of edema, is
renal problem.
Is renal.
Cardiac problem.
This is chronic renal failure, you see? And compare it with that one we have seen previously. I think that one is lobular carcinoma. Yes, this is lobular carcinoma, and this is renal failure. Compare the two sides. Look here. This is the whole breast equally. The increased density is faint and equal. You see? While here there is another added density. You see? But this is a case of carcinoma and this is chronic renal failure. What about this one? This case 1 and case 2. What do you think? Magdalene. What do you think?
The right breast, there is a global asymmetry with diffuse breast edema in form of thick trabeculation and diffuse skin thickening and nipple retraction. So these BIRAD 4C.
Excellent.
And about the other breast, there is a diffuse edema of the breast in form of thick trabeculation and diffuse skin thickening. No underlying mass seen, and there is vascular calcification.
Most patients having calcifications, okay.
This benign vascular calcification of the left breast.
Okay, huh? The right one also have vascular calcifications. Huh?
There is asymmetry. There is central or global asymmetrical density on the breast.
Global asymmetrical.
And nipple inversion.
Wait. Global asymmetrical density. We said no more use of density as descriptor in the asymmetry. Okay. This is earlier the historical.
Yeah, I'm coming late. Sorry.
Confusion. So as not
yeah, I'm coming late. I'm not attend the beginning of the lecture. I'm so sorry.
No problem. So no more use of density. The word density. Okay.
Okay.
So,
okay.
Global asymmetry. Yes. So what's your impression?
With nipple.
So you are going to report it as birat.
4C.
Even this one is chronic renal failure. We are going to report it as birat 4 until proven there is no cancer.
Yeah. Okay.
So this will be reported as.
I think more than 4C. I give her 5 because there is associated feature, nipple retraction and asymmetry. But the left one I will report as 4 because the nipple is not retracted and no.
No, there is retraction. There is retraction.
It's mild, yeah.
And there is also global asymmetry. There is global asymmetry here. But this is, yes, associated with distortion. And here there is no obvious distortion or suspicious classification. So both this one, I'll go for 5. And this I will go for 4C. See? Both are, and even, you see, even with systemic cause of edema, you see, sometimes you might see, if edema is much more, you might see some nipple retraction, but usually not as much as this, the edema, yani. Unless the cause is chronic and long time and there is dependent edema and these issues. And here I could find some global asymmetry. I need to clarify this global asymmetry to make sure there is no underlying focal lesion. So I will report it as suspicious. Both are suspicious. And I don't remember.
But the right one more suspicious.
The right one is more suspicious. I agree with you. The right one is more suspicious because there is distortion and there is some tethering. See, there is a layer of distortion and there is some tethering. You see, I'm pulling of the areolar skin, and there is significant much more thickening. See, I think both are malignancy. Both cases are malignancy. And in case of inflammatory carcinoma, what do you expect? Sometimes mammography, or yani the presentations of the underlying breast malignancy is much less presented on mammography. If I remember, around 60 plus, okay, can demonstrate the malignant masses. Why? Because of the overlying edema, and because usually in inflammatory carcinoma, the masses are small interconnecting nodules, small, rather than a large mass. And that is why MRI is superior, in this case, to mammography, and presenting the abnormality much more better. You see, this is an inflammatory carcinoma. Okay. What about this? Suhair, this case for you.
Craniocaudal and the mediolateral oblique view showing global asymmetry. But I see asymmetry at the craniocaudal view, retroareolar.
Excellent. You change your mind. So?
Yes.
So?
Yes, this is, I have to do compression, spot magnification view.
Again, you have seen what?
Asymmetry, retroareolar area at craniocaudal view.
Okay. What else?
You have to do, I think in the mediolateral oblique, there is a added density at the left, at the axillary, at the axilla representing lymph node enlargement.
Okay.
So you have spot compression.
So when you have seen asymmetry or focal asymmetry, you have to describe if there is any associated features.
Yes.
Any associated feature?
Yes, associated with focal retroareolar skin thickening.
Yes. So.
Yes. So you have to do compression, spot compression view for this area.
If not done.
An ultrasound.
Okay, ultrasound. So you are going to report it as?
For asymmetry with associated focal skin thickening, retroareolar focal skin thickening, and axillary lymph node enlargement. This is suspicious. You have to do ultrasound and do it by RAT4.
By RAT4, okay.
Yes.
So this is the second round after 1 year.
After 1 year, the area of asymmetry increase in size in craniocaudal view.
So still you will say asymmetry, or then it will be.
And also, retroareolar skin thickening is a.
So it will be focal asymmetry. You could not see more density in that. The density is not more in the CC, in the MLO.
At CC. MLO. Yes, this area.
Yes.
No.
So in the retroareolar there is increased density. So this is
focal asymmetry.
Focal asymmetry. So, and you will label it as.
It persists at another.
Look. This is the earlier, and this is the 1 year. So
increase in size.
So,
this focal asymmetry increase in size, persist and increase in size.
So
developing asymmetry.
So this is a developing asymmetry. It's our patients, and it was a developing asymmetry. Look for the, you see, this is a CC view, this is the previous, and that is the current.
Yes.
You see, some malignancies, yani not so progressive. That yani low grade malignancies, the progression little bit low, and that was a cancer. This patient having cancer.
Yes.
He was our patient. So we described before the associated features. Associated features can be associated with any abnormality in the breast. The same associated features with the mass can be the associated features with asymmetry. Skin thickening, nipple retraction, skin retractions, trabecular thickening, axillary adenopathy, architectural distortion, or calcifications, as we describe it. So we finish all. Let us go for the locations. Okay. Just Sarah Abnaouf. Are you there or left?
Yes, I'm here.
Yes. Just localize for me this Is it what is the type of asymmetry in this schematic view?
This is an focal asymmetry.
Excellent, focal asymmetry. Just localized.
Yes. This is
What is the location?
Upper outer quadrant.
Upper outer quadrant. Okay. This
Yes.
is by the quadrants.
Yes.
So the location is only by quadrants. We have
also can be by an clock.
Okay. What at
Yes,
what
this
o'clock?
is 6 1. This is this about 2 o'clock.
This is right breast.
Yes. Right. Oh, sorry.
Imagine you are doing ultrasound.
Yes.
What are the clocks in the upper outer in the right breast?
This is either 11 or 10.
What do you think? Okay. Between 11 and 10 accepted from you. Okay.
Yes, I think this is around 10
Okay.
o'clock. 10
Excellent. Well done.
Yes.
That is it. If they ask you, you will say the lesion at 10 o'clock upper outer quadrant.
Yes.
That is it.
Yes.
Where? 10 o'clock of what?
10 o'clock of the right breast, Dr. Rabab.
You didn't mention right breast. I was waiting to say right.
This is the right breast, 10 o'clock of the right breast.
Even before we said what is the remaining descriptors regarding the location. We mentioned we have many descriptors. First, laterality, right, left. Second,
then
quadrant,
this is, outer, middle, or inner.
Quadrant and clockwise. This second.
Yes. Then outer, yani in CC, outer, middle, or mid or inner.
Okay, so the depths. Okay, and the remaining it will be the regarding the location. You describe
the distance from the nipple.
Yes.
Distance from the nipple. So yes, laterality in the right breast. Quadrant and clockwise, upper outer quadrant about 10 o'clock.
10 o'clock.
In depth in the middle.
Middle.
This is the distance from the red arrow or the red line representing the distance from the nipple. Okay.
From the nipple.
These are the locations. Just to show the locations of the lesions. Describe the locations. Okay. Describe for me this one. Another, you or another one? Another.
No problem. I can proceed. No problem.
Proceed. Yalla, proceed.
This is the left breast. This is in the also outer upper quadrant. Outer upper quadrant. This is either on the left side also either either 1 o'clock or 2 o'clock on the left side.
Why you said either 2 o'clock or 1 o'clock?
No. This is this is 1 o'clock, Dr. Rabab.
Why you said 1 o'clock?
On CC, it seems to be. This is upper.
This is
upper outer.
This is CC view. This line at what o'clock?
This is either 6 or 12. This 12 here.
Yes, 6 or 12. Okay. Since we are upper, we consider it 12.
Yes.
So this is 12. Going outer
1
from here.
Then 2 o'clock.
Go here to 1. So where it will be 2 and 3. If this one.
2 o'clock, Dr. Rabak. 2, not 1. Sorry.
Oh, this is 2 o'clock. Okay.
Yes. Okay.
Upper outer 2 o'clock and the depth.
The middle.
Middle, yes. And still you did not say the left.
First thing I mentioned, this is left. First thing.
Okay, alas, okay. Sorry for
No
that.
problem.
Okay, so it is left
Upper outer at 2 o'clock, middle
third,
then
with
the
distance
from the nipple.
Yes, okay. So it is talking about what? A mass or asymmetry or distortion? You are talking about the lesion is the descriptor is what? A mass, asymmetry, or what?
Focal asymmetry. This is a focal asymmetry.
Excellent. This is a focal asymmetry. Yes, this is a focal asymmetry. It's a focal asymmetry. Yes, excellent. It is left, middle, upper, outer quadrant about 2 o'clock. Okay. So we'll do local compression and ultrasound does not show mass. So it is just a parenchymal superimposition. Superimpositions. Okay. So if I have seen a focal an asymmetry in one view, okay, what is the next step I supposed to do?
Focal asymmetry in what, Dr. Rabah?
In one projection. If I have seen an asymmetry in one projection, so what is the next step? I suppose just to report it as asymmetry, or I have to clarify.
I will do this is compression, spot compression first.
Okay, before doing the spot compression, before that,
I will do lateral, through lateral.
Okay, so I have to clarify and to make sure, is it this asymmetry is really seen on one projections or it's supposed to be seen in another projection?
Yes.
I would like to make sure, is it just an asymmetry or focal asymmetry?
Yes.
Okay.
Okay.
Okay. What about this one? Huh? I'm running fast. Would you like to continue?
No problem. I will continue.
Okay. Dr. Iman is there? I didn't hear from her. Okay. Any volunteer? Let us continue.
I will continue. Anyone, or I will continue?
If you like to continue, tell me. Yalla, tell me about this one.
This is the post-breast CC and mediolateral oblique view. On the left mediolateral oblique, there is an area of asymmetry in the...
Yes. So this is an asymmetry.
Yes.
Tell me, are you confident to label it as asymmetry, or it might be a focal asymmetry? This is my question.
It might be a focal asymmetry.
Why? How you can prove it? It might be a focal asymmetry. Why it is not seen in the CC view? Can you defend yourself? First of all, the breast is fatty. So there is no a lot of fibroglandular parenchyma to obscure it. This is one issue. The other issue, the lesion is far from the chest wall. So it's supposed to be included. It is not in the posterior breast. To say that it might be cut. Huh?
Okay.
So it is already, it's supposed to be within the included part of the breast.
Yes.
So, and here, and usually in the CC view, if I have seen asymmetry in the CC view, it's more considerable than MLO. Why? Why? Because the breast in the CC view is more, you see, more uniform, and we can do better compression than on MLO. And if I have seen any asymmetry on the CC view, it will be more concerning than the MLO. But I have to consider all at the end and to clarify. But since I haven't here any superimposition of tissue and the area is clearly fatty, and this is even sizable area of focal asymmetry, if it is real one, it's supposed to be visualized in the contralateral view. See? So I will consider it as an asymmetry. Okay?
Yes.
Yes. I will consider it as asymmetry. Okay.
Okay.
And they mentioned that if the asymmetry here, it is due to a summation artifact. They said when the focal asymmetry not due to summation artifact, the probability of malignancy will raise to 10%. So it will be BIRAT 4. If it is not summation artifact, we'll go for BIRAT 4 or for BIRAT 4B even. You see? But this one reported as BIRAT 1 because it was not seen in the other view and it was clearly. So if we have
معلش دكتورة رباب، معلش دكتورة رباب.
Yes.
بس الصوت كان انقطع شوية وجانا راجع.
Okay. Okay. I'll describe it here again. Let me show it to you. Okay. Type. An asymmetry can be confidently be assessed as representing summation shadow without need for additional mammographic view, like in the previous case. The asymmetry is visible only on one view of the two standard views, mammographic views. The asymmetry is sufficiently anterior to the chest wall. That is must be included in the image. Okay, field of view. On the other standard view, I'll go back for you to describe it there. The breast has sufficient fat content that on the standard view not showing the asymmetry. There is no concern about substantial additional dense tissue obscuring the asymmetry. Like the case of Hana before, you see that complex fibroadenoma, it was obscured by the dense fibroglandular tissue. Although it was a light 4 centimeter mass, but it was obscured by the tissue. But in the previous case, you have no fibroglandular tissue to obscure that opacity. If it is there, the area is completely fatty. And the lesion is more anterior, not expected to be not included in the image. Okay? And it was still seen on MLO only. And if we have previous, we can compare with. Now you got it, Magdalene, or I will repeat it for you here. We said this focal asymmetry is seen only on MLO, but it is more in the mid to anterior breast. So there is no chance, you see, to be cut it in the posterior breast in the CC view. If it is close to the chest wall, you might say not included in the CC view, but its positions is more anterior. But there is no chance to be not included in the CC view. And the other things, this is sizable, expected to be visualized here. And there is no fibroglandular tissue that might obscure it. The breast is completely fatty. So here I'll be confidently to say this is summation artifacts and it is BIRAD 1. You got it?
Yes, okay.
Yeah.
Thank you.
Okay, this is on this, yeah. On this situation, you might confidently say this is BIRAD 1 or BIRAD 2 or whatever, if seen in one view, but the other view, okay, is completely fatty, or there is no significant substantial fibroglandular tissue might obscure that asymmetry, and the asymmetry is in the mid or anterior breast, not in the posterior breast, so not expected to be outside or cut it on that view. And if we have previous, we might use it to compare with. Okay, so another, if we have seen it, you see, in one view, we have two methods looking for the asymmetry in the other view. One is the arc method and the other one is the straight line method. The arc method is this one. If you have seen the lesion here, measure the distance, you see, from the nipple to the lesions, and take the same distance, you see, apply it in the other view, okay, and leave the nipple at the center and make an arc like this, and look through this arc for that asymmetry. Okay, expected to find, if it is a focal asymmetry, expected to be visualized along this arc. If you could not see it, that means it is an asymmetry. And the other view is straight line methods. Again, from here, you see, make this a line parallel to the chest wall and measure the distance from the nipple to that line parallel to the chest wall. And again, apply it in the other view, okay? The line parallel to the chest wall and the same distance, and look through that, go through that line, looking for the asymmetry. If you will not see it, so that means it is an asymmetry. It is an asymmetry, not a focal asymmetry. Okay, these are examples. You could see here asymmetry projected over the pectoralis. So seen in MLO projected over the pectoralis high up. This is location. You know that in the CC view, the area can be missed. Difficult to be visualized in the CC view is posterolateral breast toward the axillary tail, expected to be cuts or non-visualized on the CC view. For being not visualized in the CC view, this doesn't exclude the lesions to be asymmetry. It might be there. That is why, like extended lateral, you see, and the lesion is spot magnification more laterally visualized, and this is on MLO. The lesion is there, you see, and adjacent lymph node to it. That is a nodule or the focal asymmetry. And again, this is a CC view going more lateral, more toward the area, and doing the CC spot compression, and it was there. And that is the ultrasound demonstrate the suspicious lesions or a suspicious mass, as well as adjacent normal lymph node, and it was invasive ductal carcinoma, small invasive ductal carcinoma. Okay, so in this case, expected to be not included in the image because it is far posterior due to far posterior locations. You see, that is why it was expected to be non-visualized in the CC view. So how do we decide if one view asymmetry is important? Can I give suggestion?
Yes.
Can we continue next week regarding these asymmetries? Because yani, this is the not like the mass, the asymmetry a little bit not clear like in the case of the mass, to be to follow the descriptors for the mass. For the mass it was clear. This is the mass, obviously, that this is the morphology, and that this. But regarding asymmetries, we need more examples and examples and examples to make it more clear. Do you agree with me, or it is clear? That is it.
Yes, I agree with you. It is so difficult.
We agree, Dictor.
Yes, we agree.
We agree with you.
Okay, so
We agree.
because we spent 3 hours and still we have more examples, and even regarding these locations and how to follow it. And do you remember the muffin rice and let's sink?
Yes.
And the rolling view and this issue? We need time to explain it. Huh? When we could not see the asymmetry, and to do other views if we have seen it in one view, and to do the rolling view, and if the asymmetry is the superior aspect, it will, when we go, we do medial and lateral, and the density is moving, that means it is real. Okay, it will be real. It's moving lateral, moving medial. If it is not moving, if it is disappear, it might not be. If it's central, it will not move, but it will be static. If it is seen in the CC view and not seen in MLO, and we do a true lateral 90 degree and it is seen, that means it is a real one. So we need many examples for this to make it clear. But if you agree, we can stop here and we continue next Saturday, okay? Taking more examples.
Okay.
Yes, we agree.
All of you, the remaining 17 participants now, all of you agree?
Yes,
Yes,
we agree.
Yes,
We agree, Dr.
I want to hear you. Hind agree, Suhair agree, Abir agree?
Yes, we agree. Yes.
Huh?
Yes, Dr. Arab.
Okay, Abdurrahman? Okay. Okay. Okay, thank you. Thank you for your attention, and thank you for Dr. Yusuf. And inshallah, I'll meet you next Saturday. Continue talking about asymmetries. Okay?
Inshallah.
Inshallah.
Thank you very much.
Okay, thank you, Dr. Arab. جزاك خير.
وجزاكم.
إن شاء الله شكرا لك دكتورة رمضان.
Still we have examples, and still, you see? Okay. Okay, thank you. Let us see you inshallah next week.
Inshallah. Thank
جزاك
you.
الله خير دكتورة باب، جزاك الله خير.
وجزاكم
جزاك الله خير.
وجزاكم إن شاء الله.